Well, good day, everybody. This is Chris with The Ancient Scholar. I hope this video finds you all doing well. In this particular video, I'm going to talk about the phenomena of ST segment depression as sometimes seen in the setting of subendocardial ischemia. So just as a quick review, right, when we have a substantial decrease in perfusion to cardiac myocytes, right, that decrease in adenosine triphosphate due to the inability to function, the mitochondria aren't able to function normally in generally anaerobic conditions. You have a decrease of ATP, and ATP levels coupled to certain types of potassium channels, and that causes dysfunction of potassium channels, and you get a constant leak of potassium out of the cell. And then that causes a shift of the threshold potentials of those impacted myocytes. In addition to that, as this continues along, you actually have sodium channels that are affected as well. And so essentially what happens is you have this tissue that is depolarizing and repolarizing abnormally, and you essentially have a constant flow of ions out of that cell, out of the cells that then impact neighboring healthy tissues, and the healthy tissues at the border, due to this potassium and sodium leakage, it will be more likely to depolarize, and so that pushes a current. Essentially, you have a vector, a current of ions flowing from the injured ischemic cells to healthier cells. And there's a constant vector of depolarization that moves away from ischemia. All right, we said in the setting of transmural full thickness ischemia, right, that constant flow, because you have your positive electrode, say, here, and your negative electrode here, and a lead looks from negative to positive, right, because an entire thickness of the muscle walls involved, that flow is either moving away from or in opposition away from or perpendicular to the positive electrode. And on the ECG, when you have a signal that moves away from the positive electrode, that's going to manifest as negative deflection. And so essentially what you have is you just have a constant negative deflection, if you will, and the isoelectric line on the ECG gets shifted downwards, right? Or rather, downwards, if you will. Okay, so if we look at the ECG here, say your normal isoelectric line here in healthy, well-perfused tissues would be up here, and then in the setting of transmural ischemia with this vector, that's going to shift downwards. So the isoelectric line gets shifted downwards, right? And then at the end of depolarization, going into repolarization, when things reset, you do have a temporary reestablishing of the isoelectric line at its normal baseline threshold, and then you go back into that constant vector flowing away from the negative, or rather the positive electrode. And that is essentially what we say, or what some people say, is the proximate causation of the ST elevation. And so what we're going to do is we're going to talk about, well, what happens in the setting of subendocardial ischemia, or ischemia that does not involve the entire thickness of the heart? Well, something very similar. Again, you're going to have a constant flow, okay, moving from the ischemic tissue to the bordering non-ischemic tissue, right? So you're going to have a constant vector of depolarization, but unlike the setting of transmural ischemia, where you can't have flow of constant vector move toward the positive electrode, right, because it essentially is non-functional tissue here, what you're going to get in ischemia is you're going to have a constant flow, a constant vector, right? Because only part of the partial thickness, the inner part of the thickness of the wall is involved. that flow or that current of injury will constantly be moving toward the positive electrode, unlike here with transmural, where it's constantly moving away from or perpendicular to the positive electrode. So you're going to have a constant flow moving toward the positive electrode, and what has been suggested is what that is going to do is that is actually going to shift the isoelectric line up instead of down, because now I have a constant signal moving toward the positive electrode as opposed to away from or perpendicular, as is the case with transmural ischemia. And so what's going to happen is the isoelectric line is going to get shifted up because you now have a constant flow, a constant vector of depolarization moving toward the positive electrode in those leads that are impacted. And you're going to have a phenomena very similar to ST elevation. The isoelectric line is constantly shifted up. You have your P, your QRS, and then at the T wave, the ST segment, when things reset, you'll have a temporary reestablishment of the isoelectric line at the baseline where it should be, and then you go back into, right, because now you have that constant flow and it goes back up, and so you have a shifting of the ST segment down to where the isoelectric line should be. And so collectively, this is what can, at least to some extent, explain the canonical ST segment changes we see in the setting of subendocardial and transmural ischemia. And like I've said in other videos, this is certainly not a fully elucidated mechanism for what we see, and in fact we don't have a fully elucidated mechanism, but it does seem to play an important role in explaining some of what we see. So it's probably, as I've said in other videos, necessary but insufficient to fully elucidate what is going on. And there are other theories out there as well as complementary ways of looking at this, mainly what we call the systolic and diastolic current theories. And I've essentially talked about kind of the systolic paradigm, and there are some other paradigms. But what we do know fairly well is that you do have dysfunction of cardiac myocyte ion channels, and that is in some way related to the ECG changes that are manifested in the setting of ischemia, injury, and infarction. And hopefully this series of videos that I've completed has provided a little additional context for you all. Thank you so much, and we'll see you in the next video.